Assalamu alaikum everyone and good evening. I'm Dr. Nadia Al-Matroushi. I'm a consultant cardiologist and medical director of heart transplant at Cleveland Clinic Abu Dhabi. It's my pleasure today to chair today's webinar, which is titled, we're going to discuss about beyond the biopsies, about utilizing Prospera cell-free DNA for surveillance and organ transplantation. Please note that this webinar is CME accredited by DHA. At the end of the session, you will be directed to complete the short survey in order to claim your CME credit. So please make sure that you fill the short survey after this webinar to get your CME certification. So it's also my pleasure to introduce my co-chair, Dr. Amr Yusri. Dr. Amr Yusri is a consultant cardiologist specialized in heart failure and transplant and working at Majdi Yaqub Foundation in Egypt. And now let me introduce our speaker, Dr. Cesar. Dr. Cesar, physician with 30 years of experience across global pharma and medtech. He's currently serves as a director international scientific affairs and market development organ health at Natera. We're going to discuss. We'll discuss the most important topic as using of non-invasive testing to rule out rejection and also to rule out induction rejection. It's a non-invasive biomarker for allograft rejection as a prognostic, and also it's a predictive tool for outcome and as a biomarker to evaluate the response to rejection treatment and a solid organ transplantation. Dr. Cesar, please, you can go ahead with and begin the presentation.
Thank you. Thank you very much. Just give me a second and I will put the presentation up. And hopefully it's up there. So very good evening, everyone, and warm greetings from Switzerland. I'm speaking from Switzerland. And today, as the topic is beyond the biopsy and utilizing Prospera donor-derived cell-free DNA for precision surveillance across solid organ transplantation, my pleasure is to talk about bringing these novel and non-invasive molecular precision new tools that have been developed that permit allograft monitoring in solid organ transplantation. Before I start, I would like to thank, first of all, the Society for the invitation, but also our sponsors that help us tonight, as well as the entire crew and team responsible for all the technical aspects that are making this possible. So without further ado, let me start by maybe introducing once again myself, but also the company that has brought Prospera to the service of the patients. And I want to highlight here basically what Natera is, what we do, why we do it, and how we do it. Natera is a company with more than 15 years now of experience, approaching 20. We have been solely involved in the field of cell-free DNA in all its ways and possible ways of thinking about it. So I think that we definitely have a legacy and expertise and the knowledge that puts us in a very unique and a special place. As you can see here on this diagram, what you can see is that the company started in this blue line that we call it our division for women's health, obviously dedicated to DNA testing. And in around the end of 2019, more or less, we started to work as well in other applications of cell-free DNA, as you can see here in the field of oncology, but also in the field of organ health. This has been a very successful path because this has allowed us to, in 2019, to launch Prospera for kidney, our asset tool for the assessment of rejection. And later on in 2021, the test was also launched for the heart and for the lung indications. Let me make a comment on an additional product that you see here, which is Renasight. So just to clarify what this is a genetic renal panel dedicated to patients with potential genetic diseases that might lead and might cause chronic kidney disease And this is a 397 genes panel that helps us to evaluate and to diagnose the presence of genetic diseases leading into chronic kidney disease. As you can see, this is our path. Yes, our products have been widely accepted across territories, and for instance, in the case of Prospera nowadays, is being utilized in more than 60% of the transplant centers in the United States. Having said that, having introduced a bit what we do, why we do it, and how we do it, let's get into the topic. And look, I couldn't think about any better title than the one that you see here for this slide. When the future is already our present. I think it's no doubt about it that new and non-invasive molecular precision biomarkers have arrived and definitely have bring something that we did not have. I couldn't explain better than this article that you see here that was published at the end of last year in terms of what it means. And basically, what we are in front of is an innovative array of diagnostic tools that they are being developed and gradually implemented to offer precision in the prediction of rejection, helping us to assess graft injury, improving risk stratification, and guiding treatment. With this, I think that this defines the topic and the different subjects that we are going to be talking about tonight. Now, I think that we need to highlight here the arrival of this new dawn in non-invasive molecular genetic patient monitoring. This is a bit of a journey, if you like, about different things that we have been trying and things that have been tried throughout the years. Some of them successful, some of them we are still using it, some of them still new and we exactly don't use it completely. Some of them have fallen out of the wagon. But I think that the point here is that in 2020, or around the beginning of 2020, we had the arrival of donor-derived cell-free DNA, which is the subject that brings us here tonight. And I think that with the purpose of this presentation and this educational session is to show you and demonstrate the value and the utility of donor-derived cell-free DNA in the management and surveillance of patients with solid organ transplantation. So the first question is, why do we need new biomarkers in transplantation? And it might sound a bit rhetoric at this moment, especially for the audience, because I guess that if you're attending this session is because you firmly believe on the need of new biomarkers. Let me take you through this journey because I think that this is an interesting approach. Number one, regardless the kind of organ that we look at, organ failure remains being a significant problem in transplantation, in solid organ transplantation. And this is mainly driven by the late stage of antibody-mediated rejection. When we look into the kidney, for instance, yes, our short-term outcomes, let's say 5 years, we lose 1.5 out of 5 grafts, but the situation really deteriorates as the years go by. And 50% of the graft are lost after 10 years. Obviously, this is something that nobody is happy with and something that we are trying to address already for a significant number of years. The reason for this graft loss is predominantly due to immunologic reasons. So I think that we know why this is happening and we know the consequences of this. Without pointing fingers and without saying, what are the main reasons for this, the truth is that we have tools and we have been using tools, but we also know of the shortcomings of these existing tools in kidney transplantation, serum creatinine, in other disciplines, different markers that we use in order to monitor the graft function. The arrival of the donor-specific antibodies represented a significant new help, obviously to help us to evaluate risk, but not really telling us exactly what could be happening or what is happening. And of course, we have the last resource, which is the biopsy, which we know it has its limitations, and it's limited in the amount of times that we can use it. The good news, though, is that obviously throughout the years we also have come to realize that an early treatment of rejection leads to improved outcomes, and I think that probably here is where the question is, which is, can better treatment and outcomes rely on earlier detection? And I think that this is the fundamental question that we are faced with. And remarkably, once again, with the short time that donor-derived cell-free DNA has been available, already scientific societies and leading scientific societies in the field of transplantation have already incorporated donor-derived cell-free DNA as part of the standard of care. Let's quickly review this so that we all know what the recommendations are and in which dimension. Starting with kidney, the European Society of Organ Transplantation already in 2024 issued a consensus statement with regards of testing for a non-invasive diagnosis in kidney rejection. And this was simultaneously at the same time also a positioning statement from the American Society of Transplant Surgeons recommending the following, which is, we suggest clinicians consider measuring serial donor-derived cell-free DNA levels in kidney transplant recipients with a stable renal allograft function to exclude the presence of subclinical antibody-mediated rejection. Furthermore, they also stated that we recommend clinicians to measure donor-derived cell-free DNA levels in kidney transplant recipients with acute allograft dysfunction to exclude the presence of rejection, particularly antibody-mediated rejection. So I think that's two very clear statements in terms of patients with a stable renal allograft function. Yes, they can be candidates of testing and serial testing, especially to exclude the presence of subclinical antibody-mediated rejection, as well as those patients that come to us with an acute allograft dysfunction. And the test, based on the properties that we will review shortly, can help us to exclude the presence of rejection. What else is available in terms of recommendation? Also, the European Society at the same time, in the same year, 2024, issued these recommendations for heart and for lung. They are much more extensive than the paragraphs that you see here, but I just wanted to highlight probably the most relevant one. For heart, they recommend that beyond 4 weeks after transplantation, in addition to routine clinical care, donor-derived cell-free DNA measurements could be used to rule out clinical and subclinical rejection, given the high negative predictive value of this test. And in the case of lung, two recommendations. One is beyond 6 weeks of transplantation, in addition to routine clinical care, measurements could be used to rule out clinical and subclinical rejection, again, for the same reason, due to the high negative predictive value. And also beyond 6 weeks could be used to rule out infection. In addition to these recommendations, there are some additional recommendations in terms of the predictive role of donor-derived cell-free DNA in the case of clot and other respiratory infections. And last but not least, the International Society of Heart and Lung Transplantation also issued guidelines for the care of heart transplant recipients, even a bit earlier than the ones that we just saw in 2022. And in heart, they recommend that during the follow-up visits to monitor for rejection and screen for adverse events, they might include all the following, and it was in 2022 when donor-derived cell-free DNA was added into the list of parameters. So I think that this is remarkable that in such a short time, since the arrival of donor-derived cell-free DNA, the first studies that were published with regards to its use as a tool to recognize the presence of rejection, it was so quickly adopted already in some of these positioning statements and a consensus statements. The fact is that there is a significant amount of science that supports these facts. And I think that here my intent was just to show you some of the publications that have contributed to this. And in this case, you have a systematic review and a meta-analysis, in this case in kidney, highlighting, and I think that's, when we look into the result of all these studies looking into the sensitivity and the specificity and the area under the curve, you can see that donor-derived cell-free DNA is a very, very valid marker in terms of a very high sensitivity and a specificity with a very high area under the curve, which is exactly what we want in a biomarker, something that is sensitive, something that is specific, and that in the vast majority of cases is correct. Not only in kidney, the same thing has been done for heart. So there are several There is a systematic review and a meta-analysis that I would like to present here, and the same in lung. I think that probably it's not only about the fact, it's also about the consistency of the numbers that you can see, regardless whether we are talking about kidney, heart, or lung, in terms of its parameters and performance, which I think that just points out in one direction, which is about this is a good biomarker. This is definitely a good biomarker that fulfills the criteria or the criteria that we asked for a biomarker to achieve. Needless to say, at the end of 2025, there was a significant publication as well. This is a publication by a French group, which was a study that included sites not only in Europe but also in the US, and it was published in Nature Medicine. I think that two things to highlight out of this paper, which because of the share of the numbers of individuals that were subject of a study, deserves the attention. First of all, is that donor-derived cell-free DNA is clearly associated as a rejection marker. And as you can see here, levels of donor-derived cell-free DNA start to increase, and it starts to increase in all forms of rejection. The second learning of this study, and I think it's extremely interesting, is to see that donor-derived cell-free DNA is also associated with the level of immune activity. The 6 graphs that you have here clearly depict how donor-derived cell-free DNA levels increase in accordance with the increase of the severity of the lesions, and that occurs both for ABMR as well as TCMR. So definitely, again, another property or another feature for a good biomarker, not only that is sensitive, that is has a high specificity, a high area under the curve, but is also capable to inform us about the degree of severity. Now, having said all that, let's take a step back to move forward, because I need you to remember a few things that we learned at medical school. And sometimes these are things that, because of our specialty, we haven't forgotten it, but I think a refresh is always helpful. So let me take a moment and do that for you. The concept I want to review with you is the concept of the single nucleotide polymorphism. Let's start with the simplest, which is, our genetic information is contained in the DNA as a code, which is made up of 4 bases, the ones that you see here. Now, one thing that occurs into our DNA is that we can suffer small variations in the DNA sequence. And normally these occur in single base pairs, all right? As you see here depicted between these individuals, we could have a C or a G, and that would translate into a different base on the other side. What it means is that, yes, variations in our DNA in terms of single base pairs occur. Normally, these are genetic changes that occur in every person throughout the genome. The vast majority of them, they have no implication. Some others, they might. And that this is what we call the SNPs, these single changes in a single base pair that we are going to find in the sequence of the DNA. Now, bear with me the following, which is SNPs represent less than 1% of our DNA, and this is what makes us genetically different from one another. So SNPs is an important concept to understand from now on, because the technologies that we are going to be speaking about and how these technologies are based is based on this particular phenomena of the SNPs and the fact that we have several different SNPs throughout our genome. And when we look for them, we can establish differences between subjects. Now, having said that, let's for a moment land in the topic of donor-derived cell-free DNA and why donor-derived cell-free DNA reflects allograft rejection or injury. First of all and foremost, when we transplant an organ, we not only transplant an organ, we also transplant an entire genome, a genome that comes from the donor. Now, when this organ is subject of rejection or subject of injury, there's going to occur cell death. Cell death that can be in the forms of apoptosis or necrosis. In the case of rejection, is predominantly in the form of apoptosis. And this cell death will lead into this DNA containing the nucleus to exit the nucleus, to leave the cell, and to be found in the bloodstream. Now, what we're going to find in the bloodstream, we are not going to find big pieces, big stretches of DNA. What we're going to be finding is fragments of donor-derived cell-free DNA. And in this mixture in the bloodstream, we're going to find DNA from the donor or from the organ itself. And we are also going to find cell-free DNA from us, which is predominantly, the origin of it is predominantly our white blood cells. Now, what happens when these fragments of donor-derived cell-free DNA enter the bloodstream is that they will be subject of intense metabolism by nucleases. And these pieces and the long pieces will start to be cut in smaller pieces with a point around more or less 160 to 180 pair bases. Now, we can find these fragments anywhere within the body and different fluids of the body. Not only the activity of the nucleases in the plasma will help to eliminate the presence of donor-derived cell-free DNA, also the liver and the kidney will be responsible for the excretion of these fragments of donor-derived or these fragments of cell-free DNA. Now, one of the characteristics of donor-derived cell-free DNA in particular is because of the activity. This metabolic activity that occurs is so intense that it has a very short half-life. It has been calculated to be between 30 to 90 minutes, which adds an additional feature to this biomarker, which is really reflecting real-time biological activity. Because if we see an accumulation and we see increased levels of donor-derived cell-free DNA in the blood of this recipient, means that definitely there is an injury or a rejection process ongoing, which obviously overcomes the metabolism that is subject of these fragments of cell-free DNA. So having said that, understanding the origin, understanding how or what we measure and how we measure it is of importance and relevance. Now, let's go into how do we identify and how do we measure or how do we quantify this donor-derived cell-free DNA in the bloodstream. So basically, we can do it very simple. We just need a blood sample. That's all what we need. We need a blood sample because in this blood sample, when we isolate the plasma, we're going to find traces of the donor and traces of the recipient cell-free DNA, these tiny fragments that we were discussing. How can we identify these fragments, and how can we identify whether this corresponds to the donor or to the recipient? There are several methods that have been described nowadays, and in our case, we use what we call a targeted SNP identification, meaning that we are going to be targeting specific locations of the entire genome in order to identify the presence of these SNPs and evaluate then the difference in these particular positions, which will help us then to identify what DNA corresponds to the receptor and what DNA corresponds to the donor. We do that with a PCR amplification. Obviously, is a targeted amplification of these particular positions, which then give us the markers in order to be able to afterwards quantify. And again, different methods of quantification exist, from the shotgun, which is the shotgun sequencing, which is one of the modalities. Obviously, this is something that gives us an extensive, vast array of information, but also it's time consuming and expensive. We have other methods such as the quantitative PCR or the digital PCR, digital droplet PCR, also methods described for the quantification. obviously do not have the depth of read that we can accomplish and achieve with next generation sequencing, which is the way that when we have already identified the positions and we have amplified via PCR, then we can sequence these sequences and define the quantities of cell-free DNA present in the blood sample. So basically, what we get at the end of the day is the following. We get an amount of the donor cell-free DNA divided by the total amount of cell-free DNA which is contained in this blood sample. Remember, this total of cell-free DNA is the composite of the recipient DNA plus the donor-derived cell-free DNA. And this will give us a number, will give us a percentage that is what is being used as a cutoff value in order to differentiate between patients at high risk of rejection or at low risk of rejection. Good. So having reviewed this concept and having now understood a little bit better how it's done and what methods and technologies do we have available and which ones do we use, let me take you straight into our test Prospera, because I think that is the test that provides you with the accurate and the precise technology for DNA quantification. Why? Simply because of the following. Look, we are targeting almost 14,000 single nucleotide polymorphisms, or SNPs. As you can imagine, this test produces a massive volume of information and of informative data points, which are then used for the analysis to differentiate the recipient from the donor-derived cell-free DNA. Some of you might ask, why 14,000 or almost 14,000? Well, we want to make sure that we cover all the spectrum. First of all, these are SNPs that they have been created in order to be as informative as possible, but also they need to fulfill a couple of other requirements if we want to have a good biomarker, which is, number one, it's as panethic as possible, so that covers all different types of populations. Not only including the ethnicity, but also in a very particular case, which is frequent in transplantation, which is in living donation, where we have a related donor, where the similarities of the DNA between the recipient and the donor are probably much, much higher than in the case of an unrelated donor, right? So we want to make sure that we have a tool that is able to distinguish and differentiate, even in those cases of very high relatedness, so that we can really perform the test. In addition to this, in comparison to other technologies, no donor genotyping is required, and this is a significant advancement. Otherwise, we would have to take samples of material from the donor in order to be able to sequence first and to understand what are their SNPs, and then compare with the recipient. So I think that with all that together, what you have is you have a robust analytical performance that we will review in a second in terms of sensitivity, specificity, linearity, accuracy, and precision. All the parameters that you need to fulfill for a good test. And in addition to this, we have a high and consistent clinical performance across organs, the different organs where the test has been validated, and we will also visit that briefly. So moving on. This is our analytical validation study. If you are interested in this kind of topics, the reference is here, so please don't hesitate. Two things that I wanted to highlight with the slide is the following. Number one, if you want to have a good test, you have a test that needs to be linear. It has to be linear throughout the entire spectrum of the measures that the test is going to do. Here you have the linearity curves of the test for patients that were related, for patients that were unrelated, as well as the sum of both cases. As you can see, the test is phenomenal. It follows a perfect straight line. So that means that the test is sensitive and accurate for the different measures at the different values of the range. Not only that, I think that, and the table shows us this for this purpose, is how low we can go when measuring donor-derived cell-free DNA. This is extremely low, which means that the test is extremely sensitive even at very low levels. The second or the third component that I would like to highlight here is the precision. We can have a very good test, but if the test is not precise, then we don't have such a good test. And for that, we have to look at the coefficient of variability, and the coefficient of variability indicates what is the difference or of a given value, what is the variation that could, as a cause of the measure, be related to the measure itself. Well, what you can see here is the coefficient of variability of less than 2%, either at low concentration or high concentration, is below 2%, which is an exceptionally low coefficient of variation. And that's exactly what you want in a test, precision. And this is fulfilled with this number. With all this, we should not be surprised when we look into the results that have been obtained in the different clinical studies. And I just want to summarize something here for this purpose, which is when looking at, and these are 3 different clinical studies that have been performed in the indication of kidney transplant. 3 different studies with 3 different populations, 3 different designs, 3 different purposes and objectives in the study itself. There is one thing that needs to be highlighted, which is the consistency. Look at the consistency of the performance of across the different studies, looking at sensitivity, looking at the specificity, and looking at the negative predictive value of the test, as well as the area under the curve. This is remarkable. This is remarkable because that means that the test performs in a consistent manner, which, again, is an additional trait, is an additional property that you want to see in a good test. Now you might say, Cesar, okay, that's very nice. What happens to the other organs? All right, let's have a look at the heart indication, for instance. Now, bear with me because the information now is presented in a different way. So we have the studies here and we have the performance parameters here. So we need to read that in this direction of the arrow. Across 4 different studies and different population, adults, pediatrics, and so on, once again, look at the sensitivity, look at the specificity, look at the area under the curve, look at the negative predictive value, you see consistency. This can only translate into one thing. This is a significant good test for the purpose that has been designed and for its use in the clinical utility. Very well. Well, having said that, if you are still interested in reading more about Prospera and what things have we done throughout all these years, well, I invite you to look into any of these more than 30 publications that we have peer-reviewed nowadays, and yeah, take the moment if you have an interest. Now, what I want to focus now is on the clinical or where to use and how this use or how this clinical validation has occurred throughout the different organs. Because I think another important aspect when you have a test and you want to confirm that this is a good test is that you have a clinical validation of the test, but not only in one single study, you have it in more than one study. And as I was referring before, also in different populations, in different circumstances, with different goals and objectives, so that you are certain of what you have in your hands. And this is the purpose of this slide in terms of showing you, in kidney, in heart, in lung, several studies have confirmed the same results one after another. So let's have a moment and let's review that so that we understand how we can use that as a surveillance and as a monitoring tool. The first thing I want to highlight here is that is validated nowadays in the following organs, which is kidney, simultaneous pancreas, kidney, heart, and lung. Again, because of the experience gained with all these different studies, the test is available and can be used, for instance, in kidney, in adult and pediatric populations with an age limitation of patients older than 10 years. The SPK is only for adults. Heart is available for adult and pediatric with 2 different cutoffs, and I'll get into a second with it, and is also validated in lung at this moment only available for adult patients. Not only we have the validation in terms of different populations, but we also have different algorithms or different cutoffs. And that's normal because not each organ is the same, not each organ releases the same amount of donor-derived cell-free DNA. So it's normal to have different cutoffs for the different organs. There is a certain consistency, but let me take you through. In the case of kidney, we're going to call a high-risk patient if the donor-derived cell-free DNA, the fraction is above equal or above 1% or higher or equal than 78 copies per milliliter. Note, and I think this is important, that we are providing with two results. One is the fraction, and the second one is what we call the donor quantity score, which is expressed in the 78 copies per milliliter. I'll come back to it as we go along, so don't worry about it. But I just want you to be aware that for cases where we consider high risk in kidney, the one of the two parameters need to be fulfilled. In the case of SPK, is exactly the case as in kidney. In the heart, as you can see, notice that the cutoff values are much lower than the kidney. And in this case, we will call it a high risk if it's higher or equal than 0.26 or 18 copies per milliliter. And if we are talking about the population, the pediatric population for which at this moment is only available for patients older than 7 years old, we use a different cutoff of 0.15%. I know, something that one has to get familiarized, but as soon as you get with it, is straightforward. And the same then for 1% for adult lung. So different algorithms, different cutoffs, and clinically validated in all these available organs today. Now let's review very quickly, some of the evidence of the studies that have led us to this knowledge. The first one is our validation study in kidney. This is a study that shows us two very clear things, as you can see here on the slide. Number one is that the test is able to recognize and identify all types of rejection, regardless whether it's TCMR, ABMR, pure ABMR, or any case of mixed rejection between TCMR and ABMR. The second message here is the remarkable performance, the sensitivity, very high sensitivity and specificity is an area under the curve, and what we're saying, remarkable negative predictive value. So meaning that if the test is reported as negative, the probability that we are missing a rejection is exceptionally low. The second thing that the study revealed for us is what you see here on this table, which is the test was able to capture not only clinical active rejection with high sensitivity and high negative predictive value, but also subclinical active rejection in these percentages. So the test is not only sensitive, the test is accurate, the test can detect any type of rejection with great performance, but also can detect the presence of both clinical and subclinical rejection. Now, one of the things that we are always confronted in this field is that obviously we have to use a true. We have to use a true, which is most often the cases is the histology, is the biopsy, the result of the biopsy, in order to compare with the results of the donor-derived cell-free DNA. As you know, sometimes the biopsy can be tricky, can be complicated, can be difficult to assess, and sometimes might not be as useful as we intend. So one of the things that we went into was to compare, again, what is the correlation between donor-derived cell-free DNA with molecular rejection using the molecular rejection test per excellence, which is the MMDX test. Well, what the study revealed was that, similar to what we have seen before, number one, we can detect all types of rejection. In this case, under the rejection archetypes of the MMDX, this strongly correlates with the results of the MMDX. So this is a confirmation that even when we perhaps increase, the reliability using a molecular rejection model as a true, completely confirms the findings that we have seen in previous studies. Now, this was for kidney. For heart, we also had our clinical validation study, which was called the dead use study. What you can see is exactly different, but more or less exactly the same in terms of, you can see that in all cases of rejection, donor-derived cell-free DNA was elevated in comparison to cases of non-rejection, or in these cases of ACR1R, which today they are not considered as a forms of rejection. So not only that, we also saw increasing levels of donor-derived cell-free DNA in accordance with the severity of the lesions that were observed in the biopsy. So again, another feature that you want to have in a good biomarker is not only informative, it not only informs you about risk, but also tells you or can help you to understand maybe the severity of the lesions that you might be faced with. Not only one study, as we were referring before, there was a second study, the so-called DTR2 study, extension study. This is an external clinical validation study that was performed in heart transplant patients, both in pediatric and in adults. So here, for the purpose of the slide, I just put here the results of the DDU study, and here the results of the DTRT2 study, looking at the adult population. As you can see, very similar findings in terms of not only the values for donor-derived cell-free DNA, but in terms of the area under the curve and the negative predictive value, confirming once again these properties, this performance of the test in the heart indication. Not only we could compare it with a previous study, we also compare it because the study allowed, as the study was performed in adult and pediatric patients, we saw exactly the same figures in terms of performance, in terms of area under the curve and negative predictive value, confirming what we already have learned. And if we look into the pediatric patients, and of course, for those who are dealing with pediatric heart transplant patients, obviously, having a test that is able to project a 99% negative predictive value is something that makes us probably breathe very deep and very relaxed, because with such a negative predictive value, this means that probably all biopsies in this pediatric population probably can be omitted due to this high negative predictive value. Not only we found these findings in the heart, we also saw exactly the same thing in the lung. This is the VALID study. This is our clinical validation in lung transplant. Once again, donor-derived cell-free DNA elevated in cases of ACR, in cases of AMR, in comparison to stable patients. Also some elevations in patients with CLAD and in patients with some degree of infection. Overall, when we look at the performance of the test against rejection, or in the case of rejection, again, what we highlighted before, very high area under the curve, very high sensitivity and specificities, and negative predictive value, which again confirms not only what we saw in one population and not only what we saw in one organ, but also across different organs. And to finalize maybe this round, this is the result of the so-called the SLAM study. Basically, this is how does donor-derived cell-free DNA perform in single lung transplant. The study that you just saw before, the VALID study, was a study where both double lungs and single lungs were enrolled. The number of samples for the single maybe was slightly moderate. So there was a dedicated study only to look into the single lung transplant and see how the donor-derived cell-free DNA perform, in this case, Prospera. And as you can see, I mean, similar results as we have seen with the double lung. So sensitivity, specificities, very high negative predictive value. And this is of critical relevance. I mean, for those who are working in lung transplantation, you all know that single lung transplants, these are recipients at very high risk and at risk of rejection in particular. Having a test that is able to maybe bring an alternative to non-invasive methods such as biopsy can be of great benefit. So that's one thing. The second thing is that these single lung patients, normally they are frail. individuals with certain degree of comorbidities, which invasive procedures, they are poorly tolerated most of the time. So again, having a non-invasive test for this population is a significant relief. Very well, we have accomplished phase one. Ladies and gentlemen, I guess that you now recognize these four phases, right? Yes, this is the crew of the Artemis 2 that recently completed the voyage to the moon and the orbit to the moon and come back to Earth. No, I'm not inviting you for a trip to the moon at this moment, but I'm going to invite you to a little trip, if I can put it this way, to Earth and to look at things as we have them, because I think that we have evolved in such a way that now we have very interesting questions ahead of us. And how donor-derived cell-free DNA can help us to answer all these questions. I mean, in the first study that we looked at, that was the clinical validation in kidney. One of the fundamental questions that the study helped us to identify was, is donor-derived cell-free DNA better than standard tools in order to identify rejection? And the answer was yes. It was yes, because it was superior to the performance of creatinine by all means. And of course, based on the performance data that you saw. Now, maybe the second question that comes to our mind is, can donor-derived cell-free DNA detect rejection earlier than standard tools? That's an interesting one. And obviously, we have a study that has looked into it, and I will walk you through and bring you to this journey. And the last question that we pose to ourselves is, can donor-derived cell-free DNA be leveraged post-rejection? What else can we learn from donor-derived cell-free DNA after the episode? And this is what the PEDAL study has been dedicated to. And I just want to take the moment to bring you some of these fascinating and interesting results. So let's go first with the proactive study and to the question of can donor-derived cell-free DNA help us to detect rejection earlier? Well, the answer is yes. The proactive study is a study that enrolled this number of patients that you see here. At the time of analysis, more than 1,600 patients had more than 18 months of follow-up data, and for which 424 had already a biopsy performed and were included in the analysis. I'm not going to spend too much time on this slide. I want to spend time on the next slide, which is basically the same data, but just reflecting it or following maybe a model that is easier to see and understand. All right, so what we have here is the following. We had several measurements of donor-derived cell-free DNA prior to the performance of a biopsy, because the physician considered that a biopsy was necessary based on the signs and symptoms. So what we see here is that donor-derived cell-free DNA started to elevate already 5 months before the episode of antibody-mediated rejection, and with a biopsy confirmed biopsy for ABMR. So 5 months. Similar to the case of ABMR, we also saw rises of donor-derived cell-free DNA 2 months before the diagnosis of confirmed biopsy TCMR. Whilst the patients that did not reject, those patients here in the green, they just cruise with very low levels of donor-derived cell-free DNA with any other complication. So now imagine what that means. It means that now we have an opportunity to early detect rejection, which gives us a time. It gives us an opportunity to be able to define what's the issue and how are we going to address this way before maybe the picture is way too late and way too evolved. In contrast, you can see here for creatinine in the case of ABMR, incredible, but it did not move at all. So, and this is one of the parameters that we use for evaluating or using it as a monitoring tool. Only in the case of TCMR, we see an elevation of creatinine, and it was coinciding with this very late stage or 2 months prior. So we definitely have now a tool that and I think that's probably the interpretation of this study, is that when we see elevated Prospera levels of donor-derived cell-free DNA, indicates that probably we are at an increased risk for either ongoing or future rejection. And probably the best thing we can do for these patients is to monitor them very closely. The second study is the PETAL study. And the PETAL study is very simple to understand in terms of design, which is the following. Patients were invited, patients that either had a full cause biopsy or a per protocol biopsy in kidney, again, they were invited to participate. At the time of the biopsy, or prior to the biopsy, a sample for donor-derived cell-free DNA was obtained, and the biopsy was performed. With the results of the biopsy, if patients were declared as non-rejection, so that the biopsy was negative, they will continue for a 12-month follow-up where we collected additional data from these patients. In the patients where the biopsy indicated that there was rejection, additional measures of donor-derived cell-free DNA were performed at 2, 4, 6, and 8 weeks. So that we could evaluate the dynamics of donor-derived cell-free DNA during the treatment period, and then follow up for 12 months, similar to the group of patients that just did not have any sign of rejection. Okay, the good news is, as you can see here, number one in the middle panel, donor-derived cell-free DNA was elevated in the cases of rejection. All right, at the time of the biopsy. Good to know. And donor-derived cell-free DNA declined and remained more or less under the threshold in those patients that were treated. Yeah, that's very good news because that adds an additional feature. So can the biomarker help me to understand whether my treatment is successful, yes or no? And the answer is yes. Now, because we were not completely satisfied with this, we then look at the profiles of these individuals in order to see what happened to each one of them. And what we saw is very interesting, and is depicted here on the last slide. So number one, just a moment, because this thing is asking me for something. Just want to make sure. Okay. Sorry about that. I just need to confirm one thing that is happening here with my computer, and I'll be right back with you. Okay, good. So what we saw is that actually we could define 4 different profiles of patients. We saw patients that came with a very high level, and as a consequence of the treatment, the donor-derived cell-free DNA decreased below the threshold and remain below the threshold. We saw patients that came in with high levels of donor-derived cell-free DNA at the time of the biopsy, and then these levels, in spite of the treatment, did not normalize. They remain high throughout that period. We saw a group of patients that they started high. The treatment brought donor-derived cell-free DNA down, but then they had a rebound, as you can see here on this orange curve. And last but not least, we have the group of patients that came in with a relatively low donor-derived cell-free DNA, and they remain in this low DNA level. So now, not only we were able to evaluate the dynamics in general, but also we identified 4 different types of patients, or profiles, if you like, of the dynamics in terms of the response of donor-derived cell-free DNA to the treatment of rejection. We went one step further and we tried to evaluate, does this have an impact in terms of clinical outcomes, depending on the response that we see? And we classified the following. We classified negative outcomes if patients suffer from any of these conditions here, and we considered positive outcomes if they didn't have any of the above. This flow diagram tells us everything that we need to know, which is the following. This is at the time of rejection, we had patients with mix, with antibody mediated, with TCMR. Here we have the trend of the DNA in accordance with the the 4 trends that we described before: high, mid, drop, or low. And here we have the outcome. Well, I think it's very obvious to see that those patients that came high, remain high in spite of the treatment, was associated with negative outcomes. Those patients with mid, in other words, those that started high, they had a decline during treatment, but then they had a rebound in their donor cfDNA levels, was also associated to a negative outcome. And then in the those that drop and drop below, and those that remain low throughout, they had a positive outcome. So basically, I think that what the study told us about is that, first of all, trends in donor-derived cell-free DNA post-rejection might serve as a molecular indicator of treatment effectiveness, and I think that that's obvious. If we see a decline in donor-derived cell-free DNA, that would mean that the treatment has been effective. But also, it gave us some prognostic in terms of those different trends can be associated with prognostic outcomes, at least at 1 year. And I think that this is a new facet, for donor-derived cell-free DNA, and definitely a very attractive facet for the use of donor-derived cell-free DNA and Prospera in the clinical setting. Good. Excuse me. Moving on, and just to summarize a few more things, we can also use Prospera in order to optimize immunosuppression, or even to evaluate the treatment response to new therapeutic agents. This is a case of a single site, and was an observational site where they took patients and they monitored them with donor-derived cell-free DNA in order to be able to taper immunosuppression. And they did it in accordance with the donor-derived cell-free DNA levels. Or in this case, where a new treatment such as an anti-CD38 was used to treat a group of patients. And as you can see here, donor-derived cell-free DNA was used. And after the treatment, this patient not only had an amelioration in their ABMR lesions in terms of score, but also a significant drop of donor-derived cell-free DNA after treatment. Good. We are approaching an interesting point. You might wonder, is the beginning of the spring here in Switzerland, and some flowers are coming up. So let me just highlight a couple of flowers that I want to. This is coming from the trifecta study, where in the kidney indication, where we saw that donor-derived cell-free DNA can be a better predictor than DSA in terms of ABMR. The first reality that we realize is that more than 50% of ABMRs are DSA negative. When we then look into can donor-derived cell-free DNA help us to predict ABMR, we saw that actually it could do it even better than DSA. As you can see here, this is the area of the curve for the predicting antibody-mediated rejection, using the molecular microscope as a truth for rejection. So you can see that the area under the curve was 0.66 donor-derived cell-free DNA, whether we look into the fraction, whether we look into the quantity, or whether we look into a combination of donor-derived cell-free DNA plus quantity plus DSA, it significantly increases this predictability. So again, another additional feature that we can use it in conjunction with other tools that we have at our disposal in order to understand what it means and how do we need to proceed accordingly. This is also derived from the trifecta study, a very interesting paper if you have the opportunity. The paper deals about different state diseases and how donor-derived cell-free DNA is released in these different disease states. Of particular attention is the following, which is those are patients that they were considered negative in the histology. So the histology was negative for rejection. They were also subject of the MMDX, and MMDX was considered, they could not call them neither TCMRs or ABMRs simply because the threshold of the activation of the genes activated was not sufficient in order to be called or to be given this label, if you like. But in contrast, these patients had elevated levels of donor-derived cell-free DNA, which means that it is possible that what they call this subthreshold molecular ABMR light changes. So basically patients that maybe the histology is incapable, simply incapable to give us this level of precision, that with the MMDX tool, they saw that there were changes, but these changes were not sufficient in order to be given the label of a pure TCMR or pure ABMR, but indicating that there was activity, that there was immunological activity, and therefore this immunological activity was translated into increased levels of donor-derived cell-free DNA. Once again, I think a proof and a testimony that if we see a patient with a donor-derived cell-free DNA, yes, we might have a negative biopsy. In any case, do not disregard this is a patient. You don't necessarily have to act immediately, but at least this is a patient that needs definitely an elevated level of surveillance, because this is a patient that might be rejecting very soon. Now, one thing that I was alluding before, you heard me talking about we use two elements to define the risk. We use two cutoffs, we use two methods to, and two values that we provide you with this. Why? Well, the reason is the following. There are several factors that might influence total cell-free DNA, meaning that mixture of recipient plus donor. You can see here some of the factors that have been described that could have an impact on this total cell-free DNA. Now, because we have defined because we have defined the fraction as the result of a quotient between, in the numerator, we have the amount of donor-derived cell-free DNA. In the denominator, we have the total amount of cell-free DNA, which is the sum of the donor plus the recipient. We could have situations in which there is an increase in the cell-free DNA of the recipient, which means that if there is an increase in the amount of cell-free DNA from the recipient, could translate into a reduction of the fraction because it's inversely proportional. And that could leave us into a possible error, and this case could have been reported as a negative because the fraction was below the 1%, impacted by this increased amount of recipient cell-free DNA, and lead us to a false negative result. How did we address this? Is by using what I was referring before, two different values, which is the donor-derived cell-free DNA fraction in percentage, and also this estimated amount of donor-derived cell-free DNA expressed in copies per milliliter. So basically, here is how we should read this. In the case of kidney, any patient with a value above 1%, so on this side of the graph, will be called high risk. But patients with also levels higher than 78 copies per milliliter, meaning above this line, they will also be reported as high risk. Any patient with a value of the fraction less than 1 or less than 78 copies per milliliter will be called low risk or decreased risk, which with this way, we can avoid that situation that if there is an increase in the recipient cell-free DNA that could lead us to a reduction in the fraction, we always have this estimated amount of donor-derived cell-free DNA that will portray the presence of this increased risk. It doesn't happen often, but it happens in some cases. So to have those values is of extreme value in order to be able to interpret these results. This is how we arrived to this conclusion based on the trifecta study. But not only in the trifecta study, we also have done the same for heart. And that's why today, when you see the results of heart, at least for heart adults, you're going to see these two values that they are reported in order to make the perfect readout of the situation. Very briefly, there is also the same issue that we commented before with the kidney, with the trifecta study in kidney. We also have performed, and it's ongoing, the trifecta heart study. And some preliminary findings have been reported. Once again, using MMDX, confirmation of the previous findings. We can we can find elevated levels of donor cell-free DNA throughout any type of rejection. Second of all, it's very interesting, and I think these are preliminary results, so we have to see how this pans out. But actually, it doesn't look that different, rejection from kidneys and rejections from hearts in when using the molecular microscope, in terms that we see areas where there is an overlap of genes that that are expressed both or overexpressed both in the kidney and in the heart. Very interesting findings, more to come in the years to come. Maybe here is something that is for the future, because this is a series of studies that Natera is involved nowadays in indications of heart and lung. All of them are ongoing. As you can imagine, and I want to highlight, part of it was presented last week at the International Society of Heart and Lung Transplantation. Stay tuned, because there is much more to come, and that's going to be of extreme value in order to further understand the clinical utility of donor cell-free DNA in these indications. Well, now we are racing to the end. When to use it? I think that in the case of kidney, but this is applicable to all other disciplines, we have patients in which biopsies might be extremely complicated, either because they are under coagulation, or they have a coagulopathy. Patients that, because of some degree of obesity, might be difficult, or even the location of the organ, especially the kidney, because it's intra-abdominal, might make it very complicated. So these are very simple cases where we can consider the use of donor cell-free DNA as a substitute of biopsy. In the field of the surveillance, obviously, we are concerned about subclinical rejection, and this is an ideal tool because we can extract blood as many times as we want. We don't need to go to the biopsy every time. In cases where we have to reduce the immunosuppression because patients are affected by a viral disease, infectious disease, and we need to reduce immunosuppression, and we always have the fear and the concern, okay, how low can I go before I go too low? So this is another way where we can use it with confidence. Patients where we think that maybe we are over immunosuppressing and we want to optimize this immunosuppression, obviously having a companion such as donor cell-free DNA can be of extreme use in order to help us to, first of all, consider what is necessary, and second of all, to adjust the immunosuppression accordingly. And obviously there are all these patients that they fall into this bucket of high risk or high immunological risk patients. So patients that they already have a previous history of rejection, patients in which there is a new DSA appearing, patients that they have been, they were in the need of a retransplant, or patients that went into transplant with high PRAs. These are patients that we know that they are at risk, they are an increased risk. And obviously biopsy and some of the other tools that we have nowadays in our toolkit do not really fulfill our needs. And obviously, having a non-invasive instrument is definitely a great advantage for them and for us as physicians. And then the forecast, where, well, oftentimes we are confronted with a non-diagnostic biopsy, in terms of very, very difficult for the pathologist to really commit to something. We can have an equivocal biopsy in terms of we might see, but we might see other things. And so probably having donor cell-free DNA can be of extreme value to us in order to understand what is really happening. And as we were commenting before, I mean, we often not perform, but post-rejection treatment biopsies is always a complicated thing to convince the patient. And now we have a non-invasive opportunity to follow and monitor the success of the therapy. With regards to indications of use, I'm going to stop here for a second, because these are the limitations of use. In other words, when the test cannot be performed because the test has not been validated. So, number one, pregnant women at this moment, or pregnancy would be a contraindication because obviously there's going to be the presence of a third DNA there, which is the fetal DNA. We need a certain time before we can perform the test. In kidney, we have to wait for 14 days. In heart and lung, we have to wait for 4 weeks approximately. There are some limitations in terms of age. We saw it before for kidney. We cannot do it yet for patients less than 10 and for heart less than 7. For SPKs or adults. And then there is this series of other situations that we need to be mindful. In cases that patients are suffering from cancer, that could be, and that we are aware of, that could have a significance in the results of the test. Obviously, if nobody knows about it, that's a completely different thing. Obviously, the test cannot establish differences when we are transplanting an organ from an identical twin, which is an extremely infrequent situation. Patients that have received already an allogeneic cell transplant, patients that obviously they are not mentioned in any of the intended use, and patients of multi-organ transplant other than the simultaneous pancreas kidney. So, as takeaways, and this is the end. I think that we are here because we all believe that improved tools for graft monitoring are needed. And I think that now we have the possibility, we have the opportunity of early diagnosis that can lead to a rapid intervention, which we know that will lead into a better response and to improve outcomes. Nowadays, donor-derived cfDNA has emerged as a robust, reliable biomarker. I think we have gone through. It ticks all the boxes in terms of non-invasive, provides this real-time signal and allograft status, and most importantly, I mean, it now has the support from the different societies and scientific organizations. When considering this technology, pay attention to the analytical performance of the test. Pay attention how this performance has been obtained, the robustness of the clinical performance, the robustness of the clinical evidence that has been gathered with this test, because that's what gives you trust and what gives you confidence. And I hope that with this presentation, we have been able to cover that. Number one, Prospera is extremely robust and has extremely robust analytical performance in its many different dimensions, and has established a high and consistent clinical performance across organs, which makes it reliable. And I think that the clinical utility that you saw, when we combine both the fraction plus this score and copies per milliliter, has been confirmed in a series of studies, which give us really an opportunity to consider an alternative to avoid unnecessary biopsies, or to maybe rationalize the use of the biopsy when it's strictly needed. We have seen that it can be an early indicator of rejection, which means it gives us this window of opportunity to identify what's happening and what can we do in order to minimize the impact of any episode of rejection. Allows us to evaluate the response to treatment. And not only that, is that in accordance with the response, the trends in this response, we can predict and help us to predict, so risk stratify the patients and see what do we need to do next. And last but not least, obviously, an opportunity to optimize and personalize immunosuppression. So the same way that we started, I conclude this. Hope that this has been educational, informational for you. The purpose was to review the evidence and how this new tool is being implemented, and gives us really an opportunity to bring precision in predicting rejection, in assessing graft function, in improving the risk stratification and guiding treatment. With that, I'll be happy to take any questions that you might have.
Thank you, Dr. Cesar, for the very informative presentation. And it's really interesting because we use to use like all the time invasive testing, like in heart, like biopsy, to rule out rejection. But nowadays we have this blood test, special Prospera or cell-free DNA, that can help us and help us to rule out rejection and use it as also surveillance. So maybe you can start. I have a couple of questions, and please, if you have any question, you can write it in the chat box. So maybe I can start with my question, Dr. Cesar. So do you think there are any factors that may affect the sensitivity of the test?
Any factors that might affect the sensitivity of the test?
Yeah, yeah,
Um, I think that's probably one of the fundamental factors is what we were referring before in terms of we are measuring donor-derived cell-free DNA at the same time that we are measuring receptor donor-derived cell-free DNA.
yeah.
And I think that in those tests where the value is reflected on using only the fraction, so the percentage, um, maybe that's something that we need to take into consideration. That's why we introduce this double threshold, these two measures, one the fraction, completely valid, and in addition to this donor quantity score that helps us or tells us about the levels of donor-derived cell-free DNA in particular, and then the combination of these two really decreases and diminishes. Other factors that can influence. I mean, for instance, in the case of kidney, dialysis could influence, right? Or some other treatment. But obviously, knowing it and knowing that we can do it before the dialysis session will address this concern in terms of can donor cell-free DNA be impacted by a technology such as hemodialysis? Yeah.
So, yeah.
Sorry. No, no.
No,
And
no,
maybe just to conclude, I mean,
yeah,
something
yeah.
that
Mm.
maybe that we cannot think of, obviously, is if we give blood transfusions,
Exactly. That
something
was
that,
my question to you. Like,
yeah,
and blood,
okay.
blood transfusion can be a factor, like, and the test. Yeah.
It depends. It depends. I mean, it depends on what we give. I mean, if we give full blood, yes, because that's gonna contain white blood cells, and that
Mm,
could lead into. If we just give concentrate of red blood cells do not have any nucleus, so that should not have an
mm,
impact.
okay.
Yeah,
Okay. So why we have to wait for this? Like, and the heart, we have to wait 14 days before we do the
yeah,
test, and the kidney, and I don't know, can't remember how many days. But
yeah.
why do you think this?
It's very simple. It's very simple because it's the following. Uh,
Mm-hmm,
Af- After every transplant, we have the so-called ischemia reperfusion injury.
mm-hmm,
So what happens is that the body, because of this ischemia reperfusion injury, the organ will be releasing significant amount of donor-derived cell-free DNA, at least during the first days post-surgery.
mm-hmm,
These levels, they normalize very rapidly. So they really decline very rapidly. And in an average, after 7 days post-surgery, these levels, they already have achieved the trough. Now, for extra measure, we do not recommend or we do not perform the test until 14 days have passed from the surgery. That's the case of in the kidney transplant. In the case of lung and heart, is a little bit more prolonged,
mm,
simply because as well of the significance of the surgery that has been uh, and that requires slightly more time to let these levels of donor-derived cell-free DNA that have been released as a consequence not only of the ischemia reperfusion but also of the magnitude of the surgery that has been performed. And obviously, we are still in the healing and repairing process of these wounds. That's
mm-hmm.
that's what explains these windows that need to be taken into consideration before the first steps can be done.
Yeah. So, and this is available in our center at Cleveland Clinic Abu Dhabi, and we use it routinely for our patient as a surveillance. So, maybe the most common question usually we ask ourselves every time, what's the accepted dose of a prednisone? You think, like, at the beginning we give high doses of prednisone, and then there's some studied or some the recommendation they mentioned that we can use it only if the prednisone dose is less than 20. What do you think?
Ah,
Yeah.
okay. I mean, maybe you're referring to some of the gene expression profile tests that they are available.
Mhm.
Yeah, right. So some of these gene expression profiles that might be available, especially in heart, like AlloMap.
Alumab,
Uh,
yeah.
yeah, uh, there are two things that need to be taken into consideration, and you need to take into consideration. Number one is has only been validated for ACR, so for
Yeah.
cellular, not for ABMR. And
Yeah.
second of all is exactly what you were referring to, that if the patient has been treated with corticoids, that can have an impact on the gene expression at the end of the day. Yes.
So
So
if we compare the
that
test, what's the
that doesn't
difference?
occur. That doesn't occur with
Okay,
donor-derived That's the
sure.
big advantage. Yes.
And the advantage of this also, the cell-free DNA, we can rule out ACR and AMR, yeah?
Exactly.
Yes,
Exactly.
but and
Exactly.
the Alumab only ACR. Yes, that's
Correct.
incorrect.
Exactly.
Yeah,
It's only validated for ACR, not for
exactly.
ABMR. And yeah, this is one of the possible shortcomings. And now, in front of Donald Russell DNA, as you have seen from the studies, I mean, is able to, I mean, is designed to pick up ACR and AMR, yes, and with no contraindication with regards to the use of corticoids.
Okay. So also maybe another comment. I don't know, Dr. Amr, do you want to ask any question or do you comment? Okay.
Thanks, Dr. Nadia. Thank you, Dr. Caesar, for the informative lecture. I want to ask about the interval of or the frequency of the testing to detect early detection of the rejection without over testing. يعني what the interval?
Yeah, that's always the tricky question. I mean, look, I think that we all have our protocols and our clinical protocols in our units where we test not only for the different parameters, viral loads, DSAs, concentrations of immunosuppressants, and etc. So I think that, and probably this is a fundamental message to be shared, which is, look, donor cell-free DNA in isolation is gonna be helpful, but it's not gonna give you the full picture. So basically, you need to combine, the knowledge that you have with all the different things in order to really be able to interpret and to put it together. What you need to do next. What is the appropriate frequency? Look, you're gonna find different clinics doing different things as usual. I mean, you're probably not shocked by this.
Mhm.
Um, I think that obviously, like in all transplant, we have a critical period at the beginning. Patient just come out of surgery. We have our induction. We are giving them everything we can in order to avoid an early rejection. We will be adjusting immunosuppression as we go through, and I think that obviously that's a critical period to evaluate and to use donor cell-free DNA. As we pass this critical period of maybe the first 6 months, and that's what is being recommended in some of the, the groups working on it. Then you can space more the frequency of testing, maybe every 3 months, at least during the first year. In the case of heart, I mean, if patient pass the mark of the first year without an episode of rejection is always a very good sign. And then probably maybe quarterly can be done in a routine basis. But again, you're gonna see centers that they have adopted donor cell-free DNA and they have completely avoided the use of biopsies in the case of heart. You will see sites that they will do maybe in an intermediate basis, meaning that maybe the first one is going to be a biopsy because we all want to see the biopsy. Then I might do a donor cell-free DNA, and then I might be switching, in between at different intervals. I might do one or the other. I think that it's very much dependent on your program. It's very much dependent on the kind of patients that you see. is very much dependent on how often and when do you decide to change immunosuppressions, when do you perform the assays in a simultaneous manner. And I think that here is where each unit needs to define a bit their frequency of testing.
Yeah, I agree with you. I think also it depends on the patient, the history of rejection, any that's all, can play a factor. So I have one question. So
Okay.
we do a lot of combined heart and lung, heart and kidney. So do you think any study that's like any upcoming study or trial that can look at using of cell-free DNA and combine?
Very good. It's a shame. It's a shame because I realized that we were a bit starting to get a bit compromised with the time. We just published a study which is called Motor, and it's this is an acronym, and the acronym is MOTR.
Mm-hmm. Mm-hmm.
All right. So this has been our first attempt beyond simultaneous pancreas and kidney. This has been our first attempt to look into what happens to donor-derived cell-free DNA in multi-organ transplantation. And we have been looking into liver, kidney heart, kidney pancreas, and liver kidney. So these are the three main populations. There is nothing really nothing new to communicate. I think what we have seen is that obviously there is the predominance of one organ that might be predominant in terms of the release of donor-derived cell-free DNA. Something that we observe already with the simultaneous pancreas kidney. In the case of, for instance, heart, kidney, the predominant is always a bit more the kidney. I think that, as I mentioned, has been our first attempt. I think it has been an interesting learning opportunity and how to move forward on this field, because multi-organ transplantation. Obviously, it's not the frequency of a single organ, but is also a significant form of providing help to patients in need when required. And having donor-derived cell-free DNA as an additional tool can be of extreme value. Yes, indeed. Very good question. Yes.
Yeah. So, Dr. Amr, or from the attendees, any questions? So we are lucky because we have the test in our center, and we have a good experience with ordering the test and getting the result. And to be honest with you, at the beginning, we used to do biopsy and blood test, like cell-free DNA. But nowadays, we now go like toward reduce the numbers of biopsy and do more Prospera or like the test cell-free DNA, especially as you said, like after 6 months or 3 to 6 months after the transplant. And if the patient, especially no history of rejection, and it was not complicated, the transplant surgery. So I think that's a good patient. We can depend totally on the blood test and cell-free DNA and avoid or like using any intervention or invasive testing.
Yeah, as mentioned, you can start using it after 4 weeks after heart transplant. There's no that's the advantage. I think that and to the question of Dr. Usury as well, right? Each unit needs to define when do you want to use it. Maybe in your case, okay, in the first months, because you still want to see the biopsy and see what happens, and maybe you perform a biopsy. As soon as you have confirmation that this patient is doing pretty well, maybe then switch to a non-invasive is an option that obviously definitely is welcomed by the patient. I think that goes without saying. And yeah, based on the high negative predictive value, what we have seen across the different studies and indication, it definitely gives you a margin of confidence and trust. Yeah.
Yeah. So there's a question from the attendees that they ask about how do you see the cell-free DNA testing to evolve in the coming year? And will the use of AI in analyzing the sample for cell-free DNA to be the future? Using freedom.
Okay. Yeah, I mean, probably I'm responsible of this because obviously my slide was about when the future is already our present, right? So I guess that now you want me to go backwards and say, okay, this is the present, what the future looks like. I can anticipate incredible things with donor cell-free DNA in terms of look. I just mentioned some of the results that have been presented at the ISHLT this year in terms of heart and lung. Absolutely amazing in terms of how donor cell-free DNA now in heart can help us also to prognostic to risk stratify what patient will do good and maybe what patient might be on a rocky path. So, and I think that from a physician perspective, being able to understand that okay, this particular patient will require a much closer surveillance and monitoring than another one that is doing really well is a way to maximize your effort, but also a way to improve the quality of the medicine that we all want to provide, right? So that's one. From the test perspective, I think that yeah, I mean there are. I think that there are possibilities still to further improve. So I think that I'm looking forward to this as well in the probably not a very distant future. And last but not least, I would say, well, if you remember, we have been talking about heart, lung, kidney, SPK. There is a big one missing, and right, and well, I mean. It's just a matter of time now. It's just a matter of time. I mean, the studies have been done, the studies have been completed. So now it's something that is going to be coming as well, which again, I'm sure that will be welcomed by all these groups of transplant physicians. So I think that it is a bit how the future is going to look like.
Okay. Dr. Amr, do you, any other question?
Thank you, Dr. Nadia. Thank you.
My pleasure. My pleasure.
Pleasure.
My pleasure.
Thank you. Good to see you. Thank you.
So if no more question, I think we have now to reach out to the end of our webinar. And thank you so much, Dr. Cesar, for this all new information. Please try to fill out your survey after this webinar to be able to receive the CME credits. And thank you, and thank you everyone, and good night.